Hello and welcome to Skin Sense. I'm your host Jeannine George and I'm with Dr. Stephen Schleicher, and today we are talking about your new edition of the book Skin Sense.
Correct, the 2024 edition.
All right, let's see the book. So there's the doc.
It's not X-rated, okay?
It's
so
not
that's a
X-rated.
start.
It's fit for anyone who can read. And we talked about the book in detail, like generalization, when you first had the new edition. But today we wanted to focus our attention on some of the more common problems that you talk about in the book, right?
Right,
and
exactly.
Today we're talking about psoriasis.
Correct.
And eczema.
Correct.
Okay.
And the reason why we're talking about it is so many people have them, okay? Especially eczema, where, you hear statistics and you're talking 10% of the population has eczema to some degree. Okay. So, 340 million people, that's a lot of people just in the U.S., and it's worldwide too.
Tell everyone what eczema is first.
Yeah, eczema is an itchy disorder. It basically, they call it the itch that rashes.
Okay.
So it's kind of like you start itching your skin and then all of a sudden you get a rash. So it's not like, say, poison ivy where you come in contact with something. Eczema is something in your body. People with eczema have family members many times who have asthma or hay fever. So it's related somehow to the immune system, which is, kind of amazing. And we've just found a lot of things out about eczema over the past, couple of decades. Same with psoriasis. We're just learning so much.
So where does eczema where is it usually seen on the body, or where does it attack the body?
Usually eczema will affect the areas like opposite your elbows, opposite your knees, okay, your neck. But people who are severe can get it anywhere. Okay, certainly the face is commonly involved, and you see people basically scratching, and it's very tragic when you see young kids with eczema.
Can you get it on your eyelids? Isn't that?
Well, you can get eczema there, but a lot of times the eyelids is actually a rash from, say, irritation from perfume or shampoo, because the skin on the eyelids is very, very sensitive. So, but you can get eczema there. Yes. And I think, one of your kids has eczema.
Yeah, Mason. He's been on the show when he was little.
Yeah. So
behind the legs when they're, when they would go swimming, and the irritation of him rubbing and the chlorine.
Yeah, that can irritate it. And of course, weather changes can irritate it. A lot of people do worse in the cold weather with the lack of humidity. And, obviously your skin's freezing and that doesn't help, circulation in the top layers. And when your skin dries out, that's when you start to itch.
Okay.
So
you've been studying this over many, many, many years, right?
Well, I've been treating patients with eczema many years. We've done clinical studies with eczema, with new drugs for eczema too. And, it's an amazing time because, 2017, there was basically a revolution with eczema. A medicine called Dupixent, which probably everybody's heard about because, TV commercials, but it's really a wonder drug. And it was the first drug that actually targets the mechanism that causes eczema. So people with eczema seem to have an excess of, they call them cytokines, but whatever. So what these medicines do is they target the things that actually lead to eczema. And Dupixent's an injection. You get it every 2 weeks. And like I say, it's a lifesaver. It's an amazingly safe drug. People 6 months and older can use the drug.
Oh, wow.
Okay, and you don't need blood work, which is really an amazing thing. So that was the first. Okay, that was the revolution. Then we had other drugs that came out that are similar. The fact that they're injectable. Okay, a drug called Adbury, a drug called Ebglyss, which is just approved this year. Okay, to treat eczema. Another drug, nemolizumab, used to treat eczema. Some of these have fancy names, okay?
They always have fancy
names. I know,
names.
they're fancy names.
It can't be anything you could pronounce.
Like Dupixent's called Dupilumab, okay? So they don't want you to pronounce the names, they want you to...
So there's a lot of studies, and you do trial studies at your facility as well, but they do all these studies. What are there, I mean, they're relatively safe, but what are some side effects?
Well, I mean, the side effects now, we talked about the injectables, okay, for eczema. But we also have oral medicines, which came out after the injectables. I actually brought samples from the office. This one's called Rinvoq. This one's called
These are new.
Symbico.
Now these are new drugs that.
Well, they're relatively new. They're newer than, say, many of the injectables.
Okay, so
And
the injectable's safe. Then
these,
why are there other? What are the other drugs for?
well, because in medicine, not everything works for everybody.
True.
Okay, so sure, a good percentage of patients will do great with Dupixent, but there's, 30, 40% who may not respond as well as we'd like to, or who develop side effects. Now, side effects from Dupixent, you can get redness of your eyes, called the conjunctivitis.
Okay.
And, very uncommonly, but it can happen, it can be so severe that you have to stop the medicine.
Wow.
So now we have pill, and of course, some people have needle phobia. They virtually don't hurt getting these injections, okay? But some people just can't tolerate a needle. And for those people, sure, pills are really great. I mean, if you can't do a needle, you have to do a pill, especially if you have severe eczema.
Now, are these and other drugs covered by insurance, or how?
Well, that's a great question too, because nothing in medicine is cheap anymore.
No.
And when you're talking about drugs that are expensive, that are $45,000 a year, that are $90,000 a year, well, nobody can afford them unless you have coverage. Either by insurance companies or by the government or whatever, because unless you hit the Powerball, the Mega Millions,
to treat
you're
your eczema.
not going to be able to. Now, since we're talking about eczema too, I should mention that there are a couple of new topical medicines.
Okay.
Okay, the Opzelura. There's one called Zoryve, which Zoryve is used for psoriasis and eczema, but they're in place of, or to take the place of, say, topical steroids.
Okay.
Topical steroids
Now
have drawbacks, so we use these, which are in essence safer, but of course they're a lot more expensive.
Okay. So the difference between the creams and the pills and the injection
Right.
has nothing to do with how severe your
Well, it kind of does.
Oh.
Well, look at it this way. If you have eczema, say, 40% of your body, and your back's covered,
Oh, right.
or whatever, how are you going to put creams
Right.
on? Right? It's just very, very impractical. So we call these people moderate to severe eczema. Okay, so even if 10% of your body is covered, that's a lot. Even if 3% is covered and you're itching all the time,
Then you're spreading it, right?
Then if you have maybe 1% of your body covered, you have a couple of rashes,
Right.
and they go over the cream. Great. You don't even want to think about pills or injectables. But if you're itching all the time and the creams aren't working and you can't reach
Right.
where you're itching, yeah, you want to use the cream.
Now, do they work faster than others? Like, does the injection work faster
Well, that's
because
a
you're
great. That's
you know what I
another
mean?
great point. One of the market.
I have a kid with eczema.
I know you should. Dr. Jeannine.
I like that.
We just founded a new show, but yeah, one of the pluses, say, for the pills is that they actually work faster than the shots.
Wow. They
But,
work
I mean,
faster than
well,
the shots?
these pills can work within a day or two to
Okay.
relieve itching, okay, which is really, really good. But over time, what we call efficacy means how well they work. Over time, they work in a fairly similar manner. It's just that the pills do work faster by and large.
Wow.
So that's a great question, yeah.
So you see more results with the pill than the shot?
No, you don't see more results with the
Oh.
pills than the shots. You see faster results if a person's going to respond.
Got it.
Now, again, with the pills, it's the same thing. Some
Trial
people
and error.
respond. Yeah, we can't predict now which patient can respond to which treatment. It'd be great if we would. You know how much money we would save? Like, try this one. Well, of course, it's only 60,000.
Well, if someone's sensitive to pills and they don't like to swallow pills, they might want to like the shot.
Oh, yeah.
If someone
Oh,
doesn't
yeah.
like needles, they might
Yeah.
want to try
Well,
it.
look at it this way too. Some people, who wants to take a pill every day?
Right.
And some people just forget. You go, and it's just an inconvenience where they'd rather get some of the shots you only get every 4 weeks.
Right.
So that makes it very, very, very convenient to use.
Now, in the book, what is the book? Does the book talk about the examples of this?
Yeah, the book talks about all of these. Actually, two were I kind of mentioned them in passing, but two were approved after the book. That's how exciting this field is.
Wow.
It's really amazing. So I usually write a sequel to my book like every 5 or 6 years. But I may have to speed that up because, you know, the way medicine is going, it's really, really incredible. But very cool, though. Very cool. Very gratifying.
Wow, and when you help people, I know, like itching, could you imagine, like, even when you have a bug bite, you're just like itching. Could you imagine having a skin condition?
Yeah, and picture a poor little kid who's tearing himself to shreds. I mean, you're talking a kid in diapers who's tearing himself to shreds. I mean, it's really tragic. So, you know, you want to do everything you can to help people, you know, certainly when they're itching.
So eczema is one chapter in the book. Another issue, I should say, a common problem that people deal with their psoriasis. When we come back, we're going to talk about psoriasis. But again, the book is Skin Sense. What edition is this one?
Well, this is like the 4th edition. This is a 2024 edition.
Of edition. This is available through schleichermd.com. Amazon and Barnes & Noble. So if you like, you can pick up the book. It's really interesting to talk about and look at all of the do's and don'ts with certain things. And it could be very helpful for a lot of different things. But when we come back, we'll hit on psoriasis. So stay with us. And welcome back. You're watching Skin Sense here. I am your host, Jeannine George. I'm with Dr. Stephen Schleicher. And again, we're talking about the newest edition of his book, Skin Sense. Talks about different skin conditions. But today we're focusing, taking a deeper dive into psoriasis and eczema.
Correct.
What is the difference between eczema and psoriasis?
Well, that's a good question. They're totally different creatures.
Right.
Psoriasis is characterized for the most part by these thick plaques that people get, these white areas. And remember when we talked about eczema, we said that eczema involves primarily behind the elbows and behind the knees. Well, psoriasis actually affects the elbows and the knees more often. Okay, and
so they're on
the scalp.
Opposite
they kind of are,
sides.
yeah, which is amazing. Okay, and then psoriasis, just like eczema, can occur, you know, anywhere. So, and it can be very, very disfiguring.
But it's like scaly, patchy?
Scaly patches for the most part. There are different forms of psoriasis. Some forms of psoriasis can affect only the palms and soles. Some forms of psoriasis, you become beet red. It's really like a really weird form. But yeah, but the main form is what's called plaque psoriasis, and that's when you get those thick plaques.
Okay. And is that something you can be born with?
Well, psoriasis usually starts at a later age, whereas eczema starts earlier. Some people can get psoriasis as young as, 3-5 years old, even younger. But by and large, it starts when you're a little bit older than that. Okay, many times in a teenager. Sometimes we see adults who get psoriasis for the first time.
Is that how you determine it on the location of the body?
Well, not only location, but the look.
Okay.
Okay, and psoriasis, although it can itch on occasion, it's not known to be real itchy like eczema. Eczema is known for its itchiness.
And is it affected by the weather conditions?
Psoriasis is affected by the weather in some degree by sunlight, because sunlight for most people with psoriasis is actually good. All right, so it's called ultraviolet light, and we actually treat people, and certainly before we had even more effective therapies in ultraviolet light because it's less expensive, and it does work.
Okay, so what have you learned in your recent studies
well, it's
about?
not so much right. It's not so much recent, but the psoriasis. Again, we talked about the revolution that occurred in eczema, and that was very recent. Okay, psoriasis, the revolution occurred in like the early 2000s when we had the first drug approved for psoriasis called Embro. It's an injectable, and you had to get it every week. Now we have, it's 13 injectables, and you see them on TV all the time, okay? So everybody knows what they are, the Tremfyas of the world, the Skyrizi's of the world.
All these, watch your mouth.
The Bimzelx of the world, they're, and again, just like any medicine, they're expensive, but the cool thing is they work. I mean, psoriasis is really a tragic disease because, it's very, very disfiguring cosmetically. And the therapies we used to use were, besides ultraviolet light, were kind of like the pills, but different pills, and they had side effects. Okay, so and they didn't work that well. Now it's you hate not to hate to say it, you love to say it, that virtually anyone with psoriasis can be improved. Sometimes improved 100%.
Wow, but you have to take the medicine.
You have to take the medicine. Yeah, but the way they're going, it's maybe, instead of getting a shot in the beginning you had to get a shot every week. Then it went to every 2 weeks. Then it went to every month. Then it went to every 8 weeks. Now it's every 3 months with some of the medicines. Yeah, so it may be that every 6 months or every year, someone would just need one shot to keep their psoriasis free. It's really, absolutely astounding, but very gratifying too. It's awesome. It's awesome to clear someone with psoriasis.
So do you have medications we're showing today?
Yeah, I don't have the injectables because they really need to be refrigerated. We talked about them. Okay, there's lots of them out there. Like 13 of them.
Wow.
But now there are pills too, because again, we talked about some people just don't want to get injections or have a phobia, or that it's inconvenient for them to get injections. Say they're traveling for like 6 weeks, 8 weeks. Well, where are they going to get their injections from if you have to keep it refrigerated?
Right.
So there's a couple of medicines that are out in pill form. Otezla, everybody knows Otezla because it's so widely advertised. But that's a pill that you take twice a day. And then there's another one called Sotyktu. Okay.
I love how they come up with these names.
I know.
Who comes up with these names?
So Sotyktu, I don't know how they. Well, I do know how they came up with this name because it actually combats one of the agents that helps trigger psoriasis. It gets all complicated, but yeah, that's how they got that one. There are creams. There are new creams for psoriasis too. We talked about Zoryve. And Zoryve is basically, there's a form used for eczema, there's a form used for psoriasis. And then we have Vitama, which is another cream that's used for psoriasis and soon to be approved for eczema here.
So if someone comes into your office, how do you know which one to start them with? Is it based on their history, the questions they answer?
So sometimes
pick one blindfolded?
Sometimes with these creams, patients will actually clear for X amount of months. Which is really kind of cool. So you use a cream for X amount of weeks and then you're clear for months, and patients are perfectly happy with that. If they have areas that are really like widespread, like we talked about, you can't put a cream over your whole body.
Right.
And one of the problems with psoriasis too is you have those thick plaques, and sometimes the creams just don't penetrate. And even though there is a foam for the scalp, the Zoryve comes in a foam.
Oh my gosh, I haven't thought about that. Your scalp.
Right? Yeah. To think about putting a cream or an ointment in your scalp, it's not going to work. But they do have liquids and foams out for it. But getting back to your question, if you have psoriasis that's bad, in areas, again, a lot of times people have psoriasis on their backside and backs and stuff, areas really difficult to reach. Those are people you'd want to put on either the newer pills or the injectables. Now, the other thing that we want to talk about, a fair amount of people with psoriasis have psoriatic arthritis. Okay, which are joint pains, all right? And it can be very, very, very severe.
Why do those two work together? Do we know?
Well, it has to do with the inflammation. Okay, so the triggers for psoriasis not only triggers those things that go on your skin, meaning those plaques, but it also triggers joint destruction. Okay, and then psoriasis can be crippling. So getting back to why we wouldn't use a cream. Well, if somebody has really bad psoriatic arthritis, well, cream's not going to help.
Right.
So you have to go to agents that have been proven to help both psoriasis and the psoriatic arthritis. And there's another reason too, and that we're finding more and more, there's something called comorbidities. It's a fancy name, but we've learned that people with psoriasis have problems, many times with blood pressure, have problems with being overweight, have problems with having too high a lipid count in their bloodstream. And the thinking is, well, maybe some of those are due to the inflammation that's causing the psoriasis. So that if we can somehow somehow get a hold on this inflammation and kind of untrigger psoriasis, then maybe these people will actually live longer.
Wow.
Because we're helping prevent some of the damage to the heart and cardiovascular system that this inflammation is. Now, it's kind of speculative now. Nobody's been able to really prove it, but the thinking is, well, if we can, undo the underlying inflammation, we can really help this person's whole body out.
That's amazing.
Yeah.
Now, you mentioned that this happens a little earlier or younger, a little later in life. Are the pills and the medications still safe for children then?
Yeah, that's a really good question too. And some of the injectables are safe for children. Okay. But some are approved for children, 6 years of age, 12 years of age, and even younger than that. But so it depends on which one you're using, and you have to be careful. And the main reason, I'm sure they're all safe because the safety with these is just absolutely incredible. But when you're talking about giving a medication to, say, a child that is not indicated for, meaning the FDA hasn't approved it for that age, then the insurance companies won't pay for it.
Got it. Not insurance companies.
Well, that's a big factor this day and age. So we're hoping that things will get better, because it's really heartbreaking when patients can't go on medication, and especially with Medicare, I can give you examples. We have patients who are totally clear for years using one injectable, and then they turn 65 and they can't use it anymore because it's not being covered, and we have to switch. So that's just the way healthcare is, and hopefully we'll find ways around it.
Your book again, Doc. Focuses on how many chapters are in it. It's an easy read, but basically, what's a summary of the book?
Well, the summary is, believe it or not, there's some 2,500 skin conditions, okay? Wow. That's why we train in dermatology for like 4 years. But I mean, the ones everybody's, encounters are, maybe the top 20, because everybody's heard of acne.
Right.
And that's obviously a chapter in the book. Okay, and then we get into the cosmetics because we're talking about the Botoxes and the derm,
which is
the
huge
fillers.
right now, right?
What's that?
Botox and the fillers and all that is like really huge right now.
Oh, it's huge
right now.
Yeah, and I even have a chapter on social media because what people are picking up on the internet, with the X's and the Facebooks and the Twitter, whatever. Some of it's not real.
Right.
Some of it's just false.
Right.
And people are kind of harming themselves. And there are people trying to sell products on the internet that shouldn't be sold because, but that's the way it is.
So be careful where you purchase.
Be very, very careful. Yes.
Go to a certified.
Yeah. Like 90% of what you see on the web is legit. But when you're talking 10% that is made up. Yeah. And even worse than that. You got to warn people. God,
you're going to buy these products that they're going to give you,
and there have been studies where a huge percentage of patients search the internet before they even go to a doctor. So their doctor is their iPhone. Right. So kind of scary in a way. Kind of scary.
The iPhone or Dr. Schleicher?
Yeah, be careful.
Be very careful.
Yeah.
All right, again, let me see the book. You can pick the book up. It's called Skin Sense, 2024 edition, right?
2024, yeah.
All right, you can pick it up at your own website, which is schleichermd.com, Amazon, or Barnes and Noble, right?
Super, yeah.
How long have you been doing this, practicing medicine?
Practicing medicine since 1835, I think.
He's a dinosaur at this point.
Yeah, since you were in diapers.
That's
I
right.
think.
I'm still in diapers.
Yeah, but they're different types.
They're different types.
Yeah. I was gonna say it depends, but I can't say that.
Thank you, Doc.
All right,
so check out the book. Again, a lot of useful information on here. And thanks for joining us. You're watching Skin Sense here on SSP TV.